Hello, I'm Carol Langford from the Cleveland Clinic. Very pleased to be with you today. I want to thank the American College of Rheumatology and PANLAR for this opportunity to join you at today's session. Today we're going to be discussing an update on the treatment of ANCA-associated vasculitis. I authorize the recording and disclosure of this presentation. Before we begin, some important disclosures. For those of you attending in the United States, there is only one FDA-approved agent for the treatment of ANCA-associated vasculitis. The other agents I will be discussing constitute unlabeled uses, and I have been an investigator on some of the trials in which I will be discussing. As we focus on ANCA-associated vasculitis, it's important to recognize where this fits within the schematic of our current understanding of the primary vasculitic diseases. ANCA-associated vasculitis is a recognized family member of the small vessel vasculitides and include granulomatosis with polyangiitis, GPA, microscopic polyangiitis, MPA, and eosinophilic granulomatosis with polyangiitis, EGPA Churg-Strauss. For the purposes of today's discussion, we're going to be focusing on GPA and NPA as the therapeutic approaches for EGPA are different. As we'll be discussing, clinical features play an important role in the treatment decisions for ANCA-associated vasculitis. Granulomatosis with polyangiitis is recognized by its clinical features that include a predilection to affect the upper airways, lungs, and kidneys, and histologic evidence of granulomatous inflammation, vasculitis of the small to medium-sized vessels, and pauci-immune glomerulonephritis. Although we tend to think of this in terms of the upper airways, lungs, and kidneys, this is very much a multi-system disease which can affect multiple different organ sites. This is why we can see the diversity of presentations and the wide spectrum of severity that occurs in this disease. Microscopic polyangiitis is a similar disease in having multi-system manifestations that prominently affect the lungs and kidneys. It differs from GPA in lacking granulomatous inflammation. The current treatment approaches, as we'll be discussing today for GPA and MPA, are similar, but we will be discussing some adjunctive measures that are used for the airways manifestations of GPA. In focusing on the treatment of GPA, it's important to understand the current status of the ANCA-associated vasculitides. In 2020, these remain diseases that are as yet of unknown cause. They carry the potential for organ damage and possible mortality, and they have the ability to relapse with disease recurrences in anywhere from 50 to 70% of patients. That said, these are very much treatable disorders that have therapeutic options that are available to patients, and they can be associated with long-term patient survival. Some of the keys to good patient outcome include choosing a treatment regimen that best fits the individual patient setting, aggressive use of prophylactic strategies to prevent medication side effects, effective monitoring for disease relapse as well as treatment toxicity, education of the patient and their family members as far as what to watch out for, and the use of medications according to regimens proven in clinical trials. And this will be the focus of the remainder of today's discussion. As we focus on the treatment of ANCA-associated vasculitis, we recognize that there are a number of goals. Even in 2020, this remains a potentially fatal disorder, and protection of patient survival remains our first and foremost concern. However, because of the effectiveness of our current treatment modalities, these goals have become broader to include the remission of active disease, whereby remission would be the absence of disease activity, avoidance of disease relapse, where relapse would be a return of that disease activity after remission has been achieved. And very importantly, how do we minimize treatment toxicity, particularly as this can be associated with long-term survival? As we think about the treatment, it's helpful to focus on our history. Back in the 1950s, 60s, and early 70s, there was no form of available treatment, and this was a very bad illness to have. Mortality occurred on an average of 5 months due to renal and pulmonary fatalities. With the introduction of glucocorticoids, although this prolonged survival in some instances, the median survival time remained just over 1 year. Many of us nowadays are more familiar with Dr. Fauci with his ongoing work in the COVID-19 pandemic. However, as we as rheumatologists know, early in his career, with the work of his mentor, Dr. Sheldon Wolf, he engaged in studies in systemic vasculitis, including the investigations of cyclophosphamide. And it was with these studies in the 1970s that the outcome for these patients dramatically changed. For the first time, it was possible to induce disease remission in a high percentage of these patients. Over the course of time, we gained greater experience with the use of cyclophosphamide, and we learned many important lessons. We can see that despite effective induction of remission, relapse was observed to occur, and we began to see concerns with toxicities, including opportunistic infections such as pneumocystis, as well as the development of transitional cell carcinoma of the bladder with long-term exposure to cyclophosphamide. For this reason, approaches beyond cyclophosphamide were clearly needed. And indeed, in 2020, we have a number of options available by which to treat our patients. So how do we choose which regimen to use? So if we focus on the schematic, we can see the treatment is thought of as having 2 phases. Induction, whereby active disease is brought into remission, followed by remission maintenance. So in focusing first on the induction side of the equation, we can see that we have a number of options available to us. Stratification is first based upon the degree of disease severity. As we learned more about ANCA-associated vasculitis, we came to understand that disease had a wide spectrum that not only included the severe manifestations such as alveolar hemorrhage and glomerulonephritis, but also non-severe manifestations such as sinonasal disease, involvement of the skin, joint, and lung nodules where there was no respiratory compromise. And while this remained active disease that required treatment, different therapeutic approaches could be considered. The spectrum of disease influences patient outcome as well as our treatment decisions, whereby severe disease would be treated initially with cyclophosphamide or rituximab. But for those with non-severe disease, we have the options of methotrexate or mycophenolate, or yes, we can also use rituximab. So in looking at the non-severe disease options, methotrexate was the first alternative to cyclophosphamide that was investigated in the early 1990s. In a comparative study that was examined against cyclophosphamide in patients with non-severe disease, in 100 patients, we were able to determine that methotrexate was not inferior to cyclophosphamide for remission induction of non-severe disease in patients who were eligible to receive methotrexate. A more recent investigation from 2019 investigated the use of mycophenolate mofetil in mild to moderate disease. In this study, where mycophenolate was randomized and compared to IV cyclophosphamide, both followed by azathioprine, we can see that in these 140 patients, there was a similar rate of remission induction. However, it was also observed that mycophenolate had a higher rate of relapse, although the rate of adverse events was similar, as was the rate of serious infections. This trial was initiated prior to the development of rituximab as a therapeutic option, with the goal of providing a non-cyclophosphamide option to patients who could not receive methotrexate. This was important given that cyclophosphamide affects fertility, but as we now know, mycophenolate needs to be observed carefully and avoided in women with childbearing potential who seek pregnancy. And in the United States, there are also FDA advisories regarding mycophenolate for use in men. So mycophenolate, therefore, is not inferior to cyclophosphamide for life-threatening disease, but is associated with a higher rate of relapse. Now, in shifting, though, to options we have for severe disease, rituximab as we know, is a chimeric monoclonal antibody that binds to the CD20 antigen on the surface of normal and malignant B cells, inducing B cell depletion. This was first investigated in a case report published in 2001, which was followed by a favorable, open-label, and compassionate series, supporting the need for definitive studies of efficacy in GPA and MPA. In 2010, there were 2 trials published in the New England Journal of Medicine examining rituximab compared to cyclophosphamide. In the RAVE study, rituximab given at 375 milligram per meter square per week for 4 weeks was compared to cyclophosphamide transitioning to azathioprine. This trial excluded those patients that had a creatinine of greater than 4.0 milligrams per deciliter or required mechanical ventilation. At the primary endpoint, which was being in remission and off prednisone at 6 months, rituximab was found to be as effective as cyclophosphamide, and in those who were enrolled at the time of a relapse, rituximab appeared to be more effective. The rate of adverse events was similar between both treatments, and there was a low mortality rate. This supported there that rituximab was as effective as cyclophosphamide. In the other randomized trial that was published, the RetuxVASH trial, this had both similarities and important differences. In this trial, all patients received 2 doses of intravenous cyclophosphamide, following which they were randomized to either remain on cyclophosphamide or be switched to rituximab. This trial did not have any exclusions for the degree of disease severity, and this study was also designed as a superiority trial, in which they sought to determine if rituximab was actually more effective than cyclophosphamide. What we can see from these results was that although rituximab appeared to have a similar rate of remission induction, it did not meet its primary endpoint of being superior to cyclophosphamide. It similarly had a rate of adverse events that was similar between rituximab and cyclophosphamide. It did have quite a high mortality rate of 18%. This was likely explained by the older age group with a median age of 68, as well as 20% of these patients being on dialysis, both of which have been identified as risk factors for poor outcome. So what this trial told us that, again, rituximab was as effective as cyclophosphamide, but it was not superior. So as we had 2 trials that demonstrated that rituximab was as effective for remission induction as cyclophosphamide, this raises the question about whether all patients should now be treated with rituximab in place of cyclophosphamide to induce disease remission. And the answer is not necessarily. There is a varying degree of strength of evidence for use in different settings. And if we examine the strength of that evidence, we can see that the strongest evidence does come for use in those patients who have relapsing severe disease, particularly if they have previously received cyclophosphamide, as well as those who have newly diagnosed severe disease. While the weakest evidence comes from those who have the most fulminant disease, again, those who have rapidly progressive glomerulonephritis with a creatinine of greater than 4, or those with alveolar hemorrhage requiring mechanical ventilation, who are excluded from the RAVE trial. So how do patients do after they have received rituximab? And this was examined in the long-term experience from the RAVE trial. There was found in this study to be no difference in the rate of relapse between those who received cyclophosphamide to azathioprine compared to 1 course of rituximab. And these both had about still a 30% relapse rate within 1 year. The factors that were found to be associated with an increased risk of relapse include those, not surprisingly, who had had a previous relapse, those who had a positive proteinase 3 ANCA, and those who had a phenotype of GPA as opposed to MPA. And this has also been similarly found to be risk factors in non-rituximab-based studies. This tells us then that relapses can occur after either cyclophosphamide or rituximab, such that remission maintenance options need to be considered in every patient. So if we now then turn our attention to the maintenance side of the equation, we can see that we have a number of options available to us. So what do we know about these? The first randomized trial to be conducted in ANCA-associated vasculitis examined azathioprine for remission maintenance after cyclophosphamide induction. In this important trial, we can see that cyclophosphamide and azathioprine had similar rates of relapse at 18 months. This demonstrated, therefore, that azathioprine was able to maintain remission as well as cyclophosphamide without an increase in relapse rate. There was another study which examined comparatively methotrexate versus azathioprine for remission maintenance after cyclophosphamide induction. In this study, in which the primary endpoint was based on toxicity, we can see that these two therapies had similar rates of side effects, and also that there was a similar rate of relapse that was seen. This demonstrated, therefore, that in patients who were eligible to receive either azathioprine or methotrexate, the decision about which to use could be made between the patient and their physician. Now, another randomized trial compared mycophenolate mofetil to azathioprine after cyclophosphamide induction. What we found in this study was that mycophenolate was associated with a higher rate of relapse as compared to azathioprine, although both agents had similar rates of toxicity. So therefore, although mycophenolate can remain an option for consideration for remission maintenance, particularly in patients who may not be able to take the other options or who've relapsed through those, in general, this would be a third option of those three, in that mycophenolate was less effective than azathioprine for maintaining remission. Now, more recently, rituximab has been examined as a remission maintenance agent. From this series of randomized trials conducted in France, rituximab was compared with azathioprine, which was dose reduced over time after cyclophosphamide induction. In this study of 115 patients, we can see that rituximab had a higher rate of remission sustaining as compared to azathioprine. So azathioprine was associated with a higher rate of relapse. Over longer-term follow-up, while rituximab was still superior, we can see that 42% of patients who received rituximab where this was discontinued had experienced a relapse, which raises important questions about how long to continue rituximab. So although rituximab was more effective to maintain remission, duration remains a significant concern. In trying to understand more about if there are ways to better tailor rituximab and to use this potentially less often, this has been the focus of examinations based upon lab-driven dosing, based on ANCA and CD19 count. In this second study conducted in France, in which rituximab given in a similar rate of 500 milligrams on day 0, 14, and every 6 months thereafter, this was compared against the laboratory-driven approach in which rituximab 500 milligrams was administered if the ANCA rose or if the CD19 count rose above 0. What we can see is that these two schedules of rituximab had similar rates of relapse, but when the laboratory-driven approach was used, there was a fewer number of infusions that could be given. So while there remain options as far as how to dose rituximab, this study really highlights the ongoing investigations in which we try to understand better how often to give rituximab, at what dose schedule, and how long patients may need this medication. There are other approaches in the treatment of ANCA-associated vasculitis that are non-immunosuppressive that may have importance in management of patients. Trimethoprim sulfamethoxazole has been an agent of interest dating back to the 1980s, in which this was examined for its role in treatment of isolated upper airways disease. Trimethoprim sulfa is an excellent antimicrobial agent, and for that reason, its role in this manifestation has remained questionable. While this may be of utility in patients with isolated airways disease, under close monitoring, it is important to emphasize that this should never be used alone for treatment of more severe manifestations, such as glomerulonephritis or other major organ disease. Trimethoprim sulfa has also been examined for its role in relapse prevention, and in this randomized trial published in 1996, trimethoprim sulfa was found to be associated with a longer rate of remission as compared to patients who received placebo. However, when sub-analyses were performed, only recurrences of nasal or upper airways lesions was reduced. So relapses that involved more major organ systems and thus required more aggressive immunosuppression were not prevented by the use of trimethoprim sulfa. Far and away, the most important role for trimethoprim sulfa has been its role in the prevention of pneumocystis pneumonia. This important opportunistic infection has been seen in around 10% of patients with ANCA-associated vasculitis who have been receiving induction therapy, and this does include rituximab. This infection can reach a mortality rate of upwards of 35%, such that prevention, where possible, is very important. For prophylaxis, trimethoprim sulfa, given either at a dose of 160 800 milligrams 3 times a week, or a single strength trimethoprim 80 milligrams, sulfamethoxazole 400 milligrams daily can be used. And for those patients who are sulfa-allergic, options include inhaled pentamidine, dapsone, or atovaquone. And again, we do feel that prophylaxis should be given to all ANCA-associated vasculitis receiving prednisone and another immunosuppressive agent for induction, including rituximab. A recent study of intense interest has been the investigation of plasma exchange. The PEXAVAS study is the largest study performed to date in ANCA-associated vasculitis, recently published in the New England Journal in 2020. The PEXAVAS trial is a 2x2 factorial design randomized controlled trial in which patients with ANCA-associated vasculitis with severe disease who were treated with cyclophosphamide or rituximab underwent a first randomization to either receive or not receive plasma exchange, and then a second randomization to receive standard dose or reduced dose glucocorticoids. They were then examined for the composite primary endpoint, which was that of end-stage renal disease or death. In this study of 704 patients, where 98% had renal involvement and 27% had alveolar hemorrhage, in examining the utility of plasma exchange, 28% versus 31% of those who received both plasma exchange or no plasma exchange, so thus a similar rate and did not reach any statistical significance was seen. So therefore, plasma exchange did not reduce the risk of end-stage renal disease or death in ANCA-associated vasculitis. One question that has often arisen is whether this rules out the possibility for any benefit in any patient. And as this enrolled a wide range of patients, it may not rule out the possibility of benefit in those patients with truly fulminant, life-threatening disease. In terms of reduced dose glucocorticoids, again, we can see that those who received reduced dose glucocorticoids versus standard dose glucocorticoids had similar rates of the non-inferiority. So reduced dose glucocorticoids were non-inferior to standard dose glucocorticoids with respect to end-stage renal disease or death. It was also observed that use of the reduced dose glucocorticoids resulted in fewer serious infection. Thus, there were a number of important observations made from this study that may influence how we treat these patients. I mentioned earlier that granulomatosis with polyangiitis has some important adjunctive measures in the treatment of upper airways disease. In terms of nasal care, humidification, moisturization, and irrigation play important roles. Subglottic stenosis is an important manifestation that can occur in 20% of patients that is usually unresponsive to systemic immunosuppressive therapy because of the high frequency of fibroblastic scarring that accompanies active inflammation. One modality that has been found to be effective is that of intratracheal dilation injection therapy, in which this allowed improvement of subglottic stenosis. So in conclusion, in 2020, ANCA-associated vasculitis is treatable and can be associated with long-term survival. However, ongoing concerns remain in terms of relapse, treatment toxicity, and organ damage. There are a number of exciting possibilities that lie ahead. Over the coming years, we will continue to hear more about the identification of biomarkers, in which we hope this will allow the identification of relapse and those who are at risk of relapse, and in turn guide our maintenance therapeutic decision in terms of who needs what, when, and for how long. We will seek to gain a greater understanding of pathogenesis, particularly including the genetics of these diseases. We are seeking tools for disease activity assessment, and particularly understanding patient-reported outcomes and patient perceptions regarding their disease. Cost-effectiveness assessments will continue to be important, as while these can be expensive therapies, this can be balanced by the improvement that we see in our patients and their lessening need for hospitalizations and other consequences of disease. These in turn may lead to new and refined treatment approaches, including the use of less glucocorticoids, as we've already seen some data for, and the ongoing approaches that are being investigated in novel clinical trials, including the investigation of abatacept and avacopan. So with that, I would like to thank all of you. Gracias, obrigada, to the American College of Rheumatology, PANLAR, and in particular to all of you who are in attendance today. Please be well and stay safe. Good day.